Good morning, everyone. Thank you for joining us today for this expert panel organized by the Miami Lighthouse Cortical Visual Impairment Collaborative. We are going to talk about advancing CVI awareness and innovation. The CVI Collaborative at the Lighthouse brings together many experts from different disciplines and several institutions in South Florida in order to tackle challenges presented by CVI. So today's webinar is sponsored by the Delta Gamma Foundation, who awarded a Service for Sight grant to the Miami Lighthouse. So thank you to the Delta Gamma Foundation. My name is Dr. Francois Saintfort, and I'm a professor of population health and healthcare management at Nova Southeastern University in the College of Allopathic Medicine and the College of Business and Entrepreneurship. We have a very distinguished panel of experts today. It will probably take me the full hour to go over all their accomplishments, so I'm just going to introduce them briefly to you. First, we have Dr. Carlos Mendoza Santiesteban. Dr. Mendoza is an associate professor of clinical ophthalmology at the Bascom Palmer Eye Institute at the University of Miami. He's an expert in adults and pediatric neuro-ophthalmology, in hereditary retinal diseases and optic nerve diseases, among other expertise. He has practiced for over 20 years, treating visual impairment and blindness. Dr. Mendoza has many research interests and is leading a major study of CVI at Bascom Palmer through funding from the Miami Lighthouse CVI Collaborative. So welcome, Dr. Mendoza. Next, please welcome Dr. Anuj Jayagar. Dr. Jayagar is the medical director of the Neurocritical Care Program at Nicklaus Children's Hospital in Miami. He completed his training in child neurology and neurophysiology at Boston Children's Hospital. He's board certified in child neurology, clinical neurophysiology, and neurocritical care. His research focuses on epilepsy in critically ill children and optimizing neurointensive care practices. Welcome, Dr. Jayagar. Next, please welcome Dr. John Ravenscroft, who is zooming in from the University of Edinburgh in Scotland. Dr. Ravenscroft is the chair of Childhood Visual Impairment at the University of Edinburgh. He is a psychologist and an educationalist. He is the director of the Scottish Sensory Centre, which provides career-long professional development for teachers of children with sensory impairment. He's also the president of the International Council for Educators of Children with Visual Impairment in Europe, and lectures on cerebral visual impairment, inclusive education, as well as research methods in the field. Welcome, Dr. Ravenscroft. Last but not least, please welcome Michael Berger from the Miami Lighthouse for the Blind and Visually Impaired. Michael Berger is an experienced teacher of the visually impaired with 9 years of service in the field. Originally from Utah, he earned a bachelor's degree in sociology from the University of Utah, followed by a master's in social work from DePaul University, and he then later completed a master's degree in teaching of the visually impaired at the University of Utah. He's a certified cortical visual impairment specialist. To date, he has personally conducted more than 60 CVI assessments and has taught many students with CVI in the classroom, providing tailored educational interventions and individualized accommodations and supports to meet each student's unique needs. Welcome, Michael. All right, so as you can see, we have an outstanding panel who is covering a wide range of expertise related to CVI. So this is a unique webinar, and thank you again for being here today. So I will lead the conversation with questions for the next 35 minutes or so. And then I will relay to you all panelists questions from the audience. So participants, if you have questions, please write it in the Q&A feature of the Zoom call. Not the chat, the Q&A feature, okay? So that's where I will be monitoring the questions as we go along. And then after I ask questions to the panelists, then you will have an opportunity to ask questions through me, through the Q&A feature of the Zoom. All right, so why don't we start? And I'm going to direct my first question to Dr. Mendoza. How do we define cerebral cortical visual impairments?
So well, good morning, everyone, and thank you, Francois, the Miami Lighthouse, for this generous invitation to be this morning with you and talking with such distinguished, experts on the field about CVI. I mean, one of the main things regarding CVI is that we don't have a very clear definition, okay, about the condition, but I will just tell what we understand nowadays as CVI. And it is no more than the vision impairment or vision loss or visual dysfunction associated with a brain disorder. So it's very, self-explanatory from the name itself. But we need to understand that vision is a very complex process, okay? We use more than 50 different areas of the brain to process vision. That includes almost all the different parts of the brain, and it is very easy to have a vision impairment associated with a lesion in any part of the brain. Okay, some part of the brain are more important than others. Another important part of the definition of CVI is that sometimes patients have vision loss, but they also have some problems in the optic nerve and the retina associated with that. And we talk about the CVI when the vision loss is totally out of proportion for the findings or for the vision that we expect to see in those patients with, let's say, with some retinal or optic nerve changes. So essentially is the vision loss associated with a brain disorder.
Very good, thank you. John, Anuj, Michael, do you want to add anything to regarding the definition or lack thereof of CVI?
Well, yeah, I mean, I totally agree with everything that Carlos has just said there. Absolutely, we don't have a clear definition, although the American Ophthalmology Association has released one in 2024, I think. But I think what's important is, well, for us, it's cerebral and not cortical, and I think that's important because part of those areas of the brain are subcortical features, so it's cerebral visual impairment rather than cortical visual impairment. So any definition would start with cerebral visual impairment I would like to suggest. I also think that any definition that we look at, whether it's the American Ophthalmology Association or whether it's a European one that's just about to be released in November, is that we need to incorporate the function, I think, the visual function of the child as well. And I think that is quite important because we don't want to be laid down by incorrectly by acuity, because that's not the way how we should measure cerebral vision impairment. But it's also attributed functions, I think. So I'm quite interested in some kind of a functional definition. Maybe that's because I'm a psychologist and an educator, but I think that should be included. And the spectrum that Carlos was highlighting there, a spectrum of CVI should also be included within that definition. So whatever that definition, it should start off with the word is cerebral. It should be a spectrum, and it should include some of the functions, the visual functions associated with damage to that brain, whether it's lower or higher order processing. That would be my contribution to a definition.
Yeah, I agree. And I think that the NIH had actually put out a kind of a loose definition where they said that it has to include visual function, but also functional vision. So to John's point, I think it highlights that it's not just how our acuity of how we are able to see it. Well, our brain is also very important in terms of how we process that visual information and actually make that into kind of higher order or higher level information. So that aspect also needs to be included in the CVI definition. And I think we're getting there, but I think more and more we're realizing that it's more than just one part of the visual assessment. There's kind of the full broad spectrum in terms of how we use those visual cues towards our overall functionality that's important.
Francois, one thing that I like from the comment from John and Anouk is the fact that expanding this understanding of CVI as a functional problem also allows to include patients that in the past we didn't think as physicians that they were CVI. Okay, the classical example is that we used to call CVI with a patient have vision loss and a lot of neurological disorders associated with this, motor, intellectual, verbal. But nowadays we can define CVI patients that have been classified as, ADHD or dyslexias or mild functional disorders that when we go to the MRIs or the other studies, we can exactly find the part of the brain that is affected. So expanding this concept, I think, is critical for us to move forward.
And I would agree from the educational perspective that when I first was working with kids with CVI, a lot of them were more involved and they were on that range, like processing was difficult. And I'm seeing more kids that are a little higher on that spectrum that are in an educational setting, they are more academic inclined, but they do have some processing issues that impact them in the educational setting. So it's important that we are able to identify those kids so we can get them the correct accommodations.
Excellent. Thank you so much. Carlos, what do you think? What are the causes of cerebral and cortical visual impairment for
This is
all
another
ages?
Yeah, it is another tough question, because as you can imagine, brain can be suffer damage at any age. What we discuss nowadays when we talk about cerebral visual impairment, we focus mainly in pediatric population. That's for sure. But when we talk about the whole spectrum of the disease, that will include all ages. So if we focus first in kids, we're gonna have causes that happen before birth. Okay, we call those prenatal. And that includes mainly, some congenital brain abnormalities or disorders, some genetic diseases, and also some other acquired as, infections, trauma, during the pregnancy, or sometimes, the use of certain substance, that can affect the development of the kid, in utero. So then when we talk about the delivery itself, what we call the perinatal period, then you have probably the two most important of them, which is the prematurity, and Dr. Jayakar is going to talk about that, and the hypoxia associated with delivery. So those two main things, prematurity and hypoxia, I would say that are the two most important. So many times the prematurity is also combined with hypoxia, okay? So you can have hypoxia for prematurity or sometimes also associated with the delivery itself, some kind of traumas during the delivery. And then we have the other group that are the postnatals, and those one have to do again with traumas. I live here in Florida, Miami, so near drowning episodes, in pools and things like that are very frequent. Infections are very critical. And again, some genetics and neurological metabolic condition can also be part of that. So those are the three main periods around in the pediatric population. But if you think in an older individual that suffers a brain stroke, and from there they have a hemianopsia, which is the loss of the visual field in one side, or anaphasia or the dyslexia associated with that, then the spectrum of this disease, widen. And in the adult ages, mainly cerebrovascular accidents, tumors, traumas are also the most frequent. I would say that those are the most common causes.
Very good. Anuj, do you want to add something, especially regarding neurologic etiologies?
So obviously, since we're talking about cerebral visual impairment, the etiologies are largely going to fall under the neurology sphere of things. And so CVI is the most common cause for permanent visual impairment or blindness in children, in kind of the younger children, age 1 to 3. Most of the kids with CVI typically have events, like Carlos had mentioned, in either the prenatal or perinatal period. This can occur due to a variety of reasons. In the perinatal period tied around delivery, the two most common for CVI overall are hypoxia, typically from a lack of oxygen at the time of delivery, or from prematurity where you have intraventricular hemorrhages that then cause a complication called hydrocephalus. And I'll touch on those two independently. So when we think about hypoxia around birth, you can either have the most common reason is hypoxia or perinatal asphyxia, where there's a lack of oxygen during delivery. This can cause injury to the brain in a variety of different areas, most typically in our deeper subcortical structures called the basal ganglia and the thalamus. The thalamus especially is a very, very important relay center for a lot of our visual information. So kids with thalamic injury typically have the most severe form of cerebral visual impairment. Other potential areas that get commonly affected are our white matter, kind of which can occur on both sides of the brain. This again has a lot of the connecting tracks that help for our visual processing and our visual spatial capabilities. And then you can also have focal injuries, either from hypoxic ischemic injury or from strokes. While we think of stroke as largely something that happens in the adult and elderly population, the other major population is in the neonatal age range around the time of birth. So these are all a variety of different things that can happen at the time of birth that can cause kids to be at risk for cerebral visual impairment. The other big population that we see is in our babies who are very premature. So when babies are born prematurely, especially those who we term as super preemie, which are kind of 32 weeks and under, or 28 weeks and under, are at higher risk for having what we term as intraventricular hemorrhages. We all have spaces in our brain on both sides called ventricles. And around that, there's a lot of blood vessels and very active brain that's developing as part of our normal developmental process. In premature babies, that area is very susceptible to bleeding just because it's just weaker, but still having a lot of demand in that area. So as a result, you can get bleeding within those ventricles and cause pressure to build up, kind of like a balloon blowing up. And those ventricles can get larger and compress the brain around it. Unfortunately, around that area, there's a lot of fibers that help relay signals for our visual pathways, as well as fibers that help control our motor development. So those kids who have either hypoxia or ventriculomegaly or hydrocephalus from the bleeds in prematurity, those are the kids that are going to be at higher risk for a condition called cerebral palsy, where you have a brain injury and associated neurodevelopmental impairments. So when kids with CP, there's a high concordance between CP, cerebral palsy, and cerebral visual impairment, with ranges anywhere from 26 to 83%, so quite a bit. In premature babies, especially those with intraventricular hemorrhages, the rates of CVI are kind of given any from 20 to 40%. So again, pretty broad range, but a lot of patients. And these patients we see many children in our neonatal ICUs with these conditions. Other etiologies, like Dr. Mendoza mentioned, would be head trauma, any bleeding to the brain. There's many kids who can have structural malformations of the brain that could put them at risk for CVI. Any baby, any child, or even any adult that has a meningitis or encephalitis, where there's an infection within the brain, that can cause damage and permanent injury to parts of the brain that is involved with visual pathways. And then other things that we don't typically think of as much. We see many children with seizures. There are many kids who have a high seizure burden. Their brain may look normal, but if they're having frequent seizures, there is a high risk for CVI in these patient populations as well. And then finally, we have our genetic and metabolic conditions. So kids with severe hypoglycemia at birth, or other genetic conditions where they may have abnormalities in the white matter, or the structure of their brain, are also potential reasons to cause CVI in these patients.
Excellent, thank you.
Michael, so I think it's a lot.
Yeah, Michael, you see, you have assessed many children with CVI, and you have talked extensively with the parents and caregivers. And can you comment on the most frequent causes and related conditions that you have seen in those children?
Yeah, like a lot of what the doctors are saying. So since I'm not a medical expert, typically they go through their ophthalmologist, neurologist first, and then they get diagnosed with either suspect CVI or CVI. And then the doctors refer them over to me as a teacher of the visually impaired. So a lot of what they're saying, so from the educational side, I see a lot of kids with neurologic conditions, with cerebral palsy, a lot of those backgrounds, a lot of kids born premature. Like I had a child yesterday that came, he was born at 27 weeks. And he had RLP. And so I have a lot of kids that are coming in early, and then a lot of genetic syndromes. So some ones I've never heard of, coming from my background. So, and then, there's a lot of comorbidities. So like what they were talking about, there's kind of a combination of different impacts of these children. So they're typically not just one thing impacting them. They may have multiple things. And a lot of the children that I see are typically non-ambulatory. They're usually in wheelchairs. They could have cerebral palsy. They're usually nonverbal, and they have communication needs. They're typically nonverbal. Yeah, like I was saying. So, yeah, it's a wide spectrum of kids that I'm seeing, of all ages, but it's really important that we're doing this to try and get them in as young as possible so we can get them interventions at a young age.
Very good. Well, speaking of comorbidities, Anuj, and Carlos, can you comment on on all the different comorbidities that you typically see with CVI? Or is that a very wide range?
It's kind of like we had discussed in the etiologies. It's actually way more kids than we typically had thought of before. And as a result of the wide variety of etiologies, our comorbidities are also pretty broad as well. I think it's always important to remember how important vision is in terms of the development that goes on, especially in the first few years of any child's life. Whether it's guiding motor functions, kind of helping with our posture, grabbing for things, search and recognition of shapes and objects, facial recognition, which plays a part in our development of social skills later on in life. How we view how our vision, kind of how our brain interprets the visual information, is extremely valuable for multiple different parts of child development. So obviously, if you have an impairment in that, you're going to have challenges in all those different, potentially in those different aspects of child development. So we've touched upon kind of the motor side of things. So a lot of our visual tracts are very close to our corticospinal tracts, and our corticospinal tracts are the parts of the brain that help control a lot of our motor functions. So how we move our arms and legs. So if there's damage to one, there's a risk for there being damage to the other. So one of the more common comorbidities is having dysfunction of your motor capabilities. So we think of cerebral palsy where kids can develop trouble in terms of their movements, their coordination. They may develop tightness of the muscles that require either medication, surgery, Botox, things like that. And in addition to that, they can also have pretty significant intellectual disability and developmental delays. So not just motor delays, but also fine motor skills, language delays as a result of kind of these aberrant pathways that have developed. Hearing loss is another high, kind of more prevalent comorbidity that we see with CVI that we, again, don't necessarily think about as often. We screen about it when they're in the NICU, but it's not something that we actually think about kind of later on down the line as often as we probably should. Finally, other things from our side that we see, so kids who are at risk for CVI typically may have injury to the brain. They'll be at risk for microcephaly, which is where you have a small head circumference. And the other big one that we see is seizures. And kind of as I touched on before, those kids who have seizures and have a higher seizure burden are at higher risk for having worsening of their CVI, or just kind of worse CVI and seizure burden tends to go hand in hand. And then finally, the big one that's obviously been in the news a lot for the last couple of weeks is there is a comorbidity with autism. With autism and CVI, it's very challenging because one of the things that we use to assess for autism is how well they make eye contact, what are their visual spatial skills in the room, whether they react to other people's faces or other visual cues in the room. So in kids with CVI, it's hard to assess that because they may not be able to because of the CVI aspect of their symptoms rather than them having clear autism. But nonetheless, there is still a high concordance of autism in patients with CVI. Something that's worth screening for patients because similar to CVI, there are therapies that can help with all of these things. And getting patients into therapies such as physical therapy, occupational speech, ABA are all very valuable tools to help with our overall outcome, in addition to kind of the CVI treatment that we'll get into as we go forward.
Excellent. John, I know you have access to, you're in Scotland, you have built a pretty large database of kids with CVI. Does CVI seem to affect children differently, boys versus girls, other differences from what you see?
Yes, that's a really interesting question. I was talking about this to someone just the other day, and so it's very hard to know because we don't have a large data set of children with CVI. I know that the US are trying to build a CVI registry. We have one in Scotland, and currently I'm building one in Europe. But what we do know from epidemiology studies and prevalence studies is that there seems to be more boys than girls that are affected by CVI. Now, why is this the case? Well, we could ask the medics here. That there are a range of theories. possibly related to prematurity, possibly related to boys' brains in utero, a bit more susceptible than girls' brains. But on the whole, what we see on our caseload within right across Europe, and it could be the case in the US, I just don't know, is that we see more boys than girls with CVI, right? And it's not because girls then die early. We've looked at the death figures of that, and it's absolutely the same numbers of boys and girls who die. But boys do seem to be more affected with CVI than girls. But if you're talking about how does it affect children differently, well, we've heard about the complexity of what CVI is and the spectrum of disorders that really is under that umbrella of CVI. It all depends on where the damage to that visual pathway to the visual brain is and how the processing is. And that is what we will see generally across children. So if there's damage in the occipital lobe, for example, we might expect to see damage in the lower visual field and so forth and so on. We might expect to see, if we have damage in the parietal lobe, we'll see all of the effects, the motor control that Dr. Andrew was talking about there in terms of cerebral palsy, in terms of affecting the coordinating the limbs, whether that's fine motor, whether it's gross motor, whether it's upper limbs or lower limbs. And also if we have damage in the temporal lobes area as well, and that's our library, our recognition within that as well. But it's not just affecting what you would say between the genders and the children. What we're seeing in our study and what we've seen a little bit in Australia as well is that CVI seems to be more of a public health issue as well. And what we're seeing is that those children who are from the most deprived areas of society seem to have more incidence of CVI than those from the middle to the upper part. We do see a little bit of CVI in the most affluent, and that can be a little bit related to twins, multiple births, IVF perhaps, but certainly in the lower deprivation areas within Scotland, within the UK, within Europe, we're absolutely seeing much more incidence of CVI. And I think partly the story around that is maternal health, is trying to support maternal health, whether the mom is supported well, a diet, drinking, smoking, drugs, and all of that all has an impact on the baby, of course. And what we're seeing is that CVI is much more prevalent in those areas. So it's it's a complex answer to a very simple question.
Thank you. That's very informative.
And we've seen similar things here, where basically there's been studies from the States where if you look at non-Caucasian ethnicities, the rates of CVI are higher than in Caucasians. And again, this is a complex thing, with largely tied to maternal fetal care and OBGYN level care. But we do see that amongst ethnicities, there doesn't look to be, Caucasian ethnicities, there doesn't look to be much of a difference. But overall, if you look at any others non-Caucasian ethnic group, the rates are a little bit higher.
Yeah. Very good. Well, let's switch the discussion to diagnostic and diagnosis and assessment. There are several questions in the Q&A where people obviously are interested in knowing whether there is an objective diagnostic test for CVI. When should we conduct CVI assessments as part of regular vision assessments and all those things? So Carlos, tell us what are the current diagnostic tools? What do we know about what works, what doesn't work, what are the limitations?
Sure. Well, I mean, this is a very tricky question, because you have a lot of different tools that you have to use depending on the type of patient you have in front of you. And this is the most important thing with CVI, which is valid for evaluation, for treatment, for everything. There is no one recipe that is good for everybody. This disease is so individual that you need to tailor your strategy of evaluation and your strategies of treatment for the particular kid that you have in front of you. But in general terms, as a physician, I always try to tell the parents, we have the visual system and we need to test the visual system. And the visual system, I try always to make an analogy with simple things. It's like a camera connected to the computer to a cable, okay? And even we know that most of the problem can come from the computer, that will be the brain. we need to make sure that the camera and the cables are working properly and we optimize them, to allow vision. Why I'm saying that? Because many kids with cerebral vision impairment, they also suffer from congenital defects from the eyes or the visual pathway. Going from the very simple thing, they may need very strong correction in their glasses. So some of them have congenital cataracts, some of them have retinopathy associated to the prematurity itself. And we need to control all these things and make sure that we put the eye in the best possible shape towards as a sensor as the camera. Then we need to think about the cables, which is the optic nerve and the visual pathway that connects the eye to the brain. We need to make sure that there is no optic atrophy. And if there is optic atrophy, then we need to understand which type of optic atrophy the patient have and what are the parts of the visual field or the vision itself that are impacted from this. And then from there, then we move into the brain itself and we try to understand where the problem is. And just in a very, very, I mean, simple way, once the information, so the retina, which is the sensor in the eye, is sort of like a little piece of the brain. When we are seeing, we decompose most of the visual image in the retina and we start to transmit it in different channels through the cable, the visual pathway. When it reaches the cortex, then it starts to be subdivided in multiple paths that go into different areas of the brain to be processed. I mean, colors are processed in certain part of the brain, shapes or forms are processed in some other parts, contrast in other parts, motion detection, depth perception, they go to different paths. And we call this the brain streams of visual processing. And in general, there is two important. The dorsal stream that goes from the occipital to the parietal lobe and have to do a lot with where objects are in space. That means motion recognition, stereopsis, localization of things. Or the one that go from the occipital into the temporal lobe that have to do more with the recognition itself, color, forms, okay? So then we need to understand which part of the brain is more affected. In that regard, the MRI is very useful, okay? Because we can see the hardware itself, okay? How the brain looks. And nowadays we have inside the MRI a technique that is called tractography, using something that we call Hardy, that essentially allows to draw the bundles of fibers or connections along the brain and to see which area is more impact than others, and then understand what is the visual behavior. So we need to always use a mix of structure and functional tests to understand how vision works in each particular individual. More recently, we have incorporated, a kind of we call this sweep BEP, which stands for sweep visual evolved potentials. And those allow us to measure objectively how vision is processed in the primary visual cortex. We don't need to ask the patient, what letter is this or what you see. We measure the wave of the brain associated with the size of the objects, and we can estimate, for example, the visual acuity, or we can see motion processing from that too. That's very important. We also need to understand and study how the eye moves, what is the coordination of the eyes. That's critical for vision too. So there is a lot of tests that we have to assemble. That's a battery of tests. And last but not least, after we characterize the hardware, then we need to understand the software. And this is where the neuropsychological evaluation is so important. How patients use the resources they have. Only understanding this is how you can later tailor a specific treatment or a strategy of rehabilitation for them. That's the approach we use.
Very good. John, Anuj, anything to add regarding diagnostic tests? No? All right.
Not for me. I'm not a clinician, so let's take it out of the clinic, because what you see in clinic is sometimes slightly different from what you see in the home, in the environment, in the classroom. So these absolutely very interesting clinical assessments, and whilst we can do those things, it's interesting when the child moves out of clinic and into the real world situation. That's where the fun begins for us.
Yeah.
And also very important is that sometimes you cannot achieve this in one single visit.
Yeah.
It's several times, in order to do all this comprehensive assessment. They get tired very easily. You cannot stress them too much. So there is a lot of complexities associated with that. But I will say that you need to tailor your strategy for each particular patient.
Yeah, and that's
Absolutely.
very good segue into Michael, as a teacher of the visually impaired. Tell us about the kind of assessment you perform, and then how do you use those findings from the CVI assessment to determine, most effective learning modalities, intervention in an educational settings, and what do you recommend the parents of the child to then try to do at home?
Yeah, so that's my job, is to really make sure that these children are given access to what they need to be successful. And so we really have to figure out and determine where they're at and what they need in the real world environment. So we take that information from Dr. Mendoza and from Jayakar and from all these medical specialists. And then the educational setting, we try to then conduct our own assessment. So historically, in my field of teaching the visually impaired, we've been using a couple here in the US, like mainly Dr. Christine Roman Lancey's CVI assessment range. And then we've started doing Perkins. I've looked into that one as well. But they're both good for different reasons. So historically, I've done the Dr. Christine Roman Lancey. And really what we try to do is look at each child, like you guys were saying, differentiated. So when they come in, I really want to look at their medical information. And then I try to then tie in my assessment based off what I see. So I do a parent interview. And then even I can get other OTPT perspective as well. And then I do a direct observation, and that's where I'm looking to see, are they able to view certain colors? Do they have latent viewing? Are they able to see objects that are multicolored? Do they need a black background, an overlay? Do they do better with backlit devices? There's a lot of things we're looking at during this assessment. And like what Mendoza was saying, I've had children that they get so fatigued. Like when they're having visually processed information, for them, it's very exhausting. So it may be a 5-minute window where we can really get to see their pathways and what they're looking at and how they're using their vision. The child I worked with yesterday, I got him tracking twice. He did an orange lit light. So I had to turn off the lights, he would track it. And then other than that, he fell back asleep. So it's really important. I mean, with that, I had to do a lot of parent interview, but I'm going to have the parent come back again because there's more information I feel like I can pertain and get out of that child. But then when we do the assessment from there, what's really important is I write up a report and I really try to determine what supports and accommodations these children need in the real world setting. So a lot of times they're in either school settings or they're getting a lot of specialty care. So they're getting occupational therapy, physical therapy, and then they're at the home. They might be getting specialist care at the home. So I really try to work with the specialists. So I'll meet with them after I do the assessment to then talk about what accommodations this child needs to learn and to grow. Because like what I always talk about too, a lot of times people don't realize. So they don't really understand, like, oh, say what colors do they seem to like? They're like, I don't know. So a lot of the stuff, they just don't know the information too. So it's about education. It's about getting these parents aware of, oh, there's a lot of things that I'm not even thinking about. Like if they're trying to use their vision, but the TV's on and there's background information. So a big characteristic I see with kids with with cortical visual impairment is that typically if there's anything in the peripheral or background, they typically, if they have a little higher in their range, they want to look for it, or light gazing as well. Lights can be very distracting. Movement with fans, anything in their peripheral can be really distracting. So we really want to make sure they're in a really controlled environment when we're working on vision. And if they're working on toys or looking at toys that make sound, they might just be looking towards the sound source. So we don't really know if they're using their vision. It might also be too much stimulation for them to have sound and use their vision at the same time. So sometimes I just say, we're going to have a very quiet environment, no toys with sound. We can use it as so one thing I try to work on is cause and effect. So my actions have a consequence, but I want to make sure they're actually able to see what they're looking at, because I'm looking at the vision piece. So then that's when I'll start talking with the parents. If we're working on these at home, these skills, I need you to go, I might even say, find a room in your house that's dark or lit, or put the shades down, and and the invisible board, maybe we use a backlit device, just work on lights, work on toys that are one color, work on this. And then once they're a little higher, then I'll recommend, let's say they're starting to identify some letters and shapes. I'll say, okay, we can actually put an outline of red around it or a bright color, because sometimes kids with CVI tend to like brighter colors, yellow, red, green. So I'll say, okay, and based off what they're saying, we'll put a red outline around their name, and then they have to match those letters with the red outline. So we have to tie in their vision with that. So I guess my point is each child's different, and there's a lot of accommodations and supports we can do, but it's a lot about just education and real world settings, and then educating the team members that work with them. Like I said, the OT, the PT, the speech, like they're working with these children every day, and their parents, obviously. And I'm always here to answer questions, but I really want them to be educated so they can start understanding how that child will then be, let's say they're in second grade and they're in a school setting with 30 kids. Imagine trying to learn with CVI while you have all these different stimulating things in your peripheral, in front of you, around you. So yeah, it's really important for them to be educated on what they need to do.
Very good. John, I know you have a lot of experience with a variety of assessment tools. There are many different ones in Europe. What's your perspective on this?
Yeah, so I have a slightly different perspective, in the sense that what we've heard from Michael here is just how good his expertise is, and that is excellent. And TVIs are experts, and they have to be experts. And I think one of the reasons why they have to be expert is that we just don't have enough reliable, validated, sensitive tools, right? And this really worries me in the sense that we're using tools that were designed for something else. And it's the expertise of people like Michael who are adapting those tools, whether they're from the US or whether from Europe. It's that expertise in adapting the tools to help and assess and to intervene for children with CVI. So I have a real concern, a real worry that the tools that we are using, the tools that Michael's using, the tools that I'm using, they're just adapted for something else. They've been adapted mainly for ocular impairment, and that we're using for the CVI. And there are a variety of good reasons in some cases, and there's some bad reasons in other cases. But we really just don't have enough validated specific tools for us to use across the board. And so what we get is this unequal practice where just anywhere there are some experts and there's some who haven't been quite fully trained, because the tools themselves don't afford that equality across the piece. So my perspective is I worry that we just don't have enough validated and sensitive tools for the job in hand. It will come, and they're being researched. But at the moment, we are relying on our expertise, which is great, but I'd rather also rely on expertise and validated and said, we don't know if the tools we are using are actually looking at the thing we want to look at. And that worries me.
Yeah, very good. Let's see. There are a couple questions from the audience that I'd like to raise right now. What for school-based practitioners and for parents, what symptoms should they look for, to see potentially or to suspect CVI? Is there anything that you can say about that?
I mean, yeah, definitely have to look at the medical history, for one. Number two, we definitely have to see, like, are they missing things in the class? Like, again, they might be misdiagnosed for different things like ADHD or other disorders, right? But typically that's what I would say is, like, they might even, like, a lot of times I'll have parents come in, it's like, oh, they just missed something. They're not seeing it. Like, so they raise alarm to it. They'll take them to the ophthalmologist from there. And then the ophthalmologist will then do more background, obviously, research on it. And then they can determine if the child has CVI. So I'm not a medical professional, and I would never diagnose. I always recommend going to the medical professionals that know what they're doing.
Very good. Now, John, I know that you always advocate for the role of neuropediatricians and neuropsychologists, and obviously both Dr. Jayakar and Mendoza have expertise in neurology in addition to ophthalmology. So, but can you comment on that, please?
Yeah, so, and it's not because I'm a neuropsychologist, right? So I'll just get that out of the way. So, look, one of the most common things that I get asked for is it autism? Is it CVI? Is it both? And I think I get that asked probably 2-3 times a day, right? So it's one of the most common questions I get asked, and it's really hard to get that differential diagnosis. All right. So in Scotland, our medical protocol is in order for us to diagnose higher order CVI, which is where we look at whether can the child process faces, can the child understand facial emotions, amongst other things. What we have to involve is we have to involve a neuropediatrician or a neuropsychologist in order to distinguish, is it autism or is it vision related? Remember, CVI is vision, right? It's vision. And I think that's really important because we can see. But of course, we've already heard, you can get children with autism and CVI. What that is, that's Venn diagram, that middle section. We don't know how large that is. But for me, one of the most important, and I think one of the most difficult jobs there is in the field is that neuropediatrician who is able to work and to have that differential diagnosis between, no, it is autism and it's not CVI. And I think that's why in Scotland, we have that as a protocol, and you can't have that diagnosis of CVI without them being seen by a pediatrician. Because best will in the world, ophthalmologists just don't know that stuff, right? And nor should they, right? It's not part of their job. It's not their job. So, but it is the pediatrician's job, the neuropediatrician's job. So in Scotland, it's really important that we have that neuropediatrician involvement, enabled to have that differential diagnosis.
Very good. Well, let's. Oh, I'm sorry. Go ahead.
I would say to John's point, I think it's also important from our side that even as child neurologists, we see a lot of the patients that are at high risk for CVI. It's up to us to then be like, okay, what do we think? Is this patient at risk? Do we need to refer them to Dr. Mendoza, to John, to the Miami Lighthouse, Michael? We oftentimes act as kind of that front line, if you will. And it's important for us as child neurologists to be able to detect who's at risk, to understand what are some of the symptoms of that. So that way we could triage them and get them to the right place. Because the thing is with CVI, thanks to the work of Michael and John, kids can actually get better. And that's the important thing. Oftentimes, historically as child neurologists, we may be jaded because of things we see, and we're like, oh, okay, brain injury, it is what it is, and people go, but these kids can actually do well. So getting them understanding that, detecting it early, and referring them to the right places can have significant benefit.
And that's a perfect segue. In the next 10 minutes, I'd like to talk about treatments and rehabilitation and whether it's possible to help those children. So, Carlos, can you tell us about treatments? And then I will go to Michael for rehabilitation. Oh, you're on mute, Carlos.
So I'm sorry for that. So I think that the very first concept here is that, again, there's not a treatment that works for everybody, and we do not have treatment. We don't have a curative treatment for CVI. In fact, we don't even have a good strategy, okay, that we can universally say, this is the one that works for CVI. Have to do with many things, because not enough research have been conducted in this field, and also because this is a very heterogeneous condition, and trying again to make one formula for everybody never work. I want to highlight again the importance of the job of the teachers, the parents, okay, people like Michael and John, detecting those signs early on and referring those patients to the medical doctor first to do the assessment and give the kid back to them to work to what they have. I think that this is critical. But regarding treatment, despite we don't have anything that is curative or that can treat directly CVI, we do have the opportunity, as Dr. Anouk mentioned, to improve them, to improve their function, okay? So we cannot change the hardware a lot, okay? The hardware is already damaged there. And so far, until the moment that we develop cellular therapies that allow us to repopulate and reconnect areas of the brain, we are not going to have treatment for the hardware. But we can treat the software. And if you know nowadays with the same smartphone with different software, you can do a lot of different things. I like to make that analogy, okay? You need to understand which are the strengths and the weakness of this kid. For example, if we have a patient with a CVI that have a significant impairment of the parietal occipital pathways where motion is processed, I don't think that we are going to get a lot from there because this hardware is already disrupted, okay? And this capability is not there. But this kid may have very good color perception, detailed vision. He can have good contrast perception, and we can accommodate, the life around him and train him to use those resources better. Also, we need to understand the multisensorial component in CVI. We need to understand hearing. We need to understand, their proprioception, their tactile information, in order to also understand how we can help them better. I think that at the end, everything will gonna be about which are the strengths of these particular patients, which are the weakness, okay, and have a very efficient communication between medical doctors and the rehabilitators, the teachers that are gonna be doing the work, on the field, and also to have those patients back to us, time later and say, this is where he was before, this is where the patient is now, you are doing the right thing, let's keep going there. So I think that this requires a truly multidisciplinary approach. And I also want to highlight the importance of the family, the parents. I always say there's no better doctor for my kids than their parents, okay? Because they understand them very well. They have lived with them 24/7, and they are the one that can tell us which are the kind of things that they can do, the one that they cannot. So again, there is no specific treatment. One formula is not good for everybody. You really understand the patient you have and send it to the right people for the rehabilitation. And we're working on that. That's what we are doing. We're trying to develop rehabilitation protocols with new strategies, biofig, but many others that we're working at. Okay.
So it's possible to improve, which also means that we really need to improve the assessment tool so that then we can measure the improvement over time and correct it if at all possible. So, Michael, tell us about rehabilitation and educational strategies. I mean, you already talked extensively about some of the things you do with those kids. Are there some known strategies that work better than others? Are there some devices that can help them see differently? Like there are several questions in the Q&A have to do with whether Prism might be a good idea or something. But so tell us what do you think?
Yeah, I mean, first of all, I want to talk about, again, like Dr. Mendoza said, like the interdisciplinary model is very important, and that we all work together as a team to determine what each individual child needs. Each kid with CVI is so different. Like it's easy to put them, in this box, but really they're all varied based off their medical information and their backgrounds and how they're currently doing and where they're at, what they're seeing. So it is very important to determine what is that child able to and not able to do at this time. And then, like we're trying to do, make sure we can get a data and approach like that has research behind it to then determine what these children need to be successful, and then apply that in the real world setting. So a lot of times what I do with each child is I really try to determine, like, in their setting, what educational setting they're in, how are they currently doing? How are they accessing? Who are they working with? And like, for example, like a lot of times I've noticed kids with CVI, less targets, the better. So they have worksheets that might have, 30 or 40 different things on a page. We need to get that down to have 2 to 3 targets at a time. We have a kid in first grade right now who he's learning AC, has it on iPad. He can do up to 9 targets at a time, but that's taken years of working with him. And typically I'll recommend, like with this child, he needs realistic pictures, not images of. So like a lot of times that salient features can be really hard for these kids to see. So we really need to break down and simplify where and what the child is seeing educationally. And also like what is functional for them. If a child is just learning to babble and to try to communicate something, then are we going to be teaching them 5 + 5? Probably not. So like a lot of times like it's about what the child needs, but there are things we can do that may help. Like a lot of times there's something called a light box, and we can bring in bright colored shapes, different things like that, put it on the light box. There's these fun little games you can play with them. Like everything in education, I think has to be motivated by what the kid likes and what's fun for them. So I try to bring in motivating materials that typically are based off what I feel like the child needs, and that depends on each child.
Well, I guess one of the problems we have too that you can do that at the Miami Lighthouse because you
Right.
have TVIs in the academy. The schools do not have that many TVIs.
And that's the
We have a
issue
big
is,
capacity problem.
and that's what Mendoza's saying is we got to change that approach so we can make sure that these kids that are all over the world are getting access to what they need to be successful, because a lot of times they're not, and they are failing, and that's not okay. We need to change that and make sure that we're getting them what they need. So
Well, we have only a couple minutes left, so I'd like to give you each intern some concluding words and recommendation that you'd like to share with all the participants. So I am going to start with Dr. Ravenscroft, for example.
Okay, so very briefly, my words of wisdom around CVI are, and I think it's been already said, is see the child holistically. See the child, right? See the child that it's in front of you. And Michael's just explained about that. And Andrew's talked about, and Carlos has talked about that. Each child is different. So see the child that's in front of you and, just love them. That's the best thing, right? That's it.
Wonderful, thank you. Carlos, what are your words of wisdom to conclude?
I would say keep your mind open. CVI kids or CVI prevalence could be higher than we think. Okay, we need to understand that sometimes very mild defect can be associated with that. Okay, and it's not because we are going to have a treatment for each of them, but if at least we understand how their vision works, then we can give feedback to the teacher about how to manage those patients. I think that the future will bring us a lot of things, the cellular medicine, the stem cells, the rehabilitation associated with that is very promising. We are making a lot of progress in this area. It is not for 1 year now, but for I say 5 to 10 years, we're going to be seeing a lot of options, for cellular regeneration of certain portions of the brain. So we need to stay tuned for that.
Very good. Thank you so much. Anuj, concluding remarks from you?
Yep. I think just as we've discussed, there's a lot of treatment options available. So the earlier we can detect these kids, the better off they'll be. So time is brain is kind of one of our like child neurology favorite lines. So I reiterate that for CVI as well. And we have to work as a group of pediatricians, child neurologists to basically detect these kids earlier. So that way we can get them plugged in as fast as possible.
Wonderful, thank you. And Michael, I give you the last word.
thanks. Yeah, I guess it's just connecting as a model, making sure that educators are able to understand what they're working with CVI, and that parents are big advocates for their children because nobody knows them better than the parents. So I think it's just important that we educate these parents, and then they have knowledge of what their child needs so they can advocate for that. Because a lot of times they're in big complex districts and settings that they may not get what they need. So if the parents don't know what they're advocating for, then the child may not get what they need in the real world situations. So that's really important that we work with these parents to also just support them too and say, I understand this is really hard for you too. So we care about you. We want you to succeed. We want your child to succeed, and we're here to help you.
Excellent. Well, time's up. So I want to thank all of you, Michael, John, Anuj, and Carlos. Thank you so much for sharing your expertise, and thanks to the Miami Lighthouse to have put together this thing. There's still plenty of work to do in CVI, and we are working together to try to make a difference. So thank you very much. There were lots of comments in the Q&A. thanking you for your expertise and your knowledge, and this was a very informative session. So thank you very much, and bye-bye to all the participants on the Zoom.
Thank you, Francois.
Thank you.
Thank you.